Christophe, thanks for joining. I want you to start by telling me something about the work that you're trying to do here.
The fundamental question we're addressing is how do we understand the spread, the evolution of pathogens, and how do we best control them? And we do that with mathematical modelling and pathogen genomics.
Tell me a bit about how mathematical models can be used to fight viruses or bacteria.
Most of our work at the moment is on HIV. So, we can understand at a large scale the number of new infections each year. But if we understand in more detail, which age groups, which subgroups of the population are spreading, how much they're spreading, we can design interventions which maximize the amount by which new infections can be reduced in the future.
Can you give me some examples of how your findings have actually impacted on how treatment is applied?
In the area of HIV, the big changes were working out that treating people as early as possible, universal treatment, was going to have a benefit not just for the individuals who receive the treatment, but also in terms of reducing spread from those people, since treatment is so effective at blocking spread. And the kind of results that come out of modelling indicate that it's very a worthwhile investment to treat as many people, because in the long run you can reduce new rates of infection that way.
You mentioned genomic data.
Mm-hmm.
What does that add to the study of HIV?
It adds a huge amount, I think, and we're still in the process of learning and exploring. But the key thing is that you can really start to, what otherwise looks like one very large epidemic, you can start to see is a subset of overlapping epidemics. So you can disaggregate the process of spread, and you can start to see the heterogeneities. So, for example, to take a recent example, we've been working in Uganda, and there's a very substantial epidemic along the edge of Lake Victoria and a generalized epidemic inland, and we've actually been able to show that those were disconnected epidemics, disconnected risk groups. Or we can start to see, that young men contributing disproportionately to the epidemic, which is particularly problematic because those have been the one that existing programs have not been able to reach.
What sort of challenges do you face when you're trying to do this work, both on the technical side but also on the societal side? These are very sensitive subjects that you're studying.
Many of the most affected groups are highly stigmatized. And I think it's important to show how the work can really help people access better prevention and care services, while being mindful, that it could be used to prosecute or target or stigmatize people. So we've really focused on developing sort of good governance around data to enable this work to happen. I think everybody, from the patients to clinicians upwards, realizes this work is useful and should happen.
Where do you actually do the work, or where are you recruiting individuals to participate in your studies?
The bulk of the work that I've been involved in has been in Zambia and in South Africa, but I've been working as part of a consortium, leading a consortium called the Pangaea Consortium, that's also working in Uganda and Botswana, in a variety of settings. We want to make sure, we need to intensively sample populations to be able to get at the population dynamics, but we need to do it in a number of different settings to make sure that our findings are generalizable.
These sound like challenging places to translate mathematical models into real-time decisions about treatment. How do you actually go about engaging with the local healthcare systems in these locations to make the kind of improvements that you want to see?
Well, I think the key thing is to realise, that these are partnerships. It's, we have to travel and present our work, and people need to input into our work and make sure that we're asking the right questions in the right way. But we're always working in partnership with clinicians and public health physicians and policymakers in countries, and we've had lots of really valuable input from community advisory boards in different settings.
And going back to your own work, do you have over the last few years any particular eureka moments that you could talk about?
But I can, pinpoint a few which have, that's the joy of science, is being able to think about something for a long time, and suddenly you're out for a walk and you see it in a new way. One such moment was thinking about HIV as far back as 2005, and on the back of some calculations which we were interested in the question, I was interested in the question of people very different in terms of their clinical course, how that translates to onwards transmission. And I'd done the calculations and realized that our findings were consistent with the hypothesis that the clinical severity of HIV was compatible with natural selection, with evolution having determined the severity of infection. And it was just one of those moments where, it just, from that moment on, it seemed obviously true, and a whole sort of research agenda was mapped out. It then took a good 10 years to map it out. But one of the main consequences was that there had to be an important role for viral genetic factors in the severity of infection, where previously it had been assumed that what really mattered was the host genome and the host immune response. We presented it, and they were challenging findings, and somewhat remarkably, over the years, the model's predictions have been validated repeatedly. And since then, we've sort of taught ourselves viral bioinformatics. It turns out that viruses are very small things. It turns out they're very hard to sequence and very hard to interpret the sequence data. But we're getting to the end of that particular journey, and now being able to understand and pinpoint how that works.
And do you think that finding is specific to HIV, or is that going to be a general result that you'll see cropping up in the study of lots of different pathogens?
I think the findings that evolutionary theory can explain the clinical manifestations of an infection are going to be very general, but how that works is going to be very specific in each pathogen. Another question that we've been working on for a few years now is explaining, finding evolutionary explanations for the distribution of antibiotic resistance, which is not conformed with the simple evolutionary theory. So we've tried to work out what form of evolutionary theory is consistent with the data, and that's been a very interesting journey.
So finally, tell me a bit about the problems that keep you up at night at the moment. What are the things you're really excited about?
Well, I think one of the things I'm really excited about is that for a few years now, as I mentioned, I think my team has evolved from being a team of mathematicians working on a wide range of problems to being a multidisciplinary team really focused on one or two big problems: this problem of HIV spread and evolution of virulence, and the problems of antibiotic resistance. But what we haven't quite figured out is how to make it all work together to get really new insights out of all of the data that we've been generating. So so to take an example, we've sequenced a lot of HIV genomes, and those have told us new things about HIV spread and control. But it would be really nice to be able to step back and also be able to test out some new evolutionary ideas and figure out how you discover new science from these much much expanded and much richer and much more detailed data sources than we've ever had before.